I like to cover about this enigma about male sexual dysfunction. So my take is people are getting divorced. The women are walking away from marriages, and this you already know. I know of a couple, two couples in which the wife committed suicide because the man had a problem. How to handle these poor men? And not only poor men, the poorest women in our country who like to hang themselves or to take a rat poison.
Yes,
So,
yes.
so I'm trespassing in your department. Sorry for that, but
And no, sir.
just with the blood supply comes and the penis becomes harder. And it's all due to nitric oxide. Higher the score, better it is. And these are 5 here. Then we got 11 questions here. I'll just give you around 10-15 seconds to read this. So you should know that they use low intensity shockwave treatment. Or in case they have some mild vasculogenic erectile dysfunction, they use something called LI-SWT. Just want to park this idea in your mind, and then the people use such vacuum devices. Just want to park this idea in your mind that these things are also available to us. But I think we should limit ourselves to today. In case you have part 2 of this class, we'll talk more. But today we should park our mind in diagnosing it. In case we're able to diagnose this problem, we are done. For ejaculatory dysfunction, I've told you about 2 tools. And for premature, this is how do you define ejaculation is what has been written here. And then we normally give somebody a questionnaire to fill. And after he has filled the questionnaire, and then we start rating him. There are these few questions at all we have. In case you look at it, there are some criteria written on the top where we say not difficult, somewhat difficult, moderate, very difficult, extremely difficult. So we found that when you spoke about SHIM, or we talk about the erectile dysfunction issues, we said score should be low. Now, in case we look at this thing coming here, score should be high there, and here it is other way around. We find that in case we talk about do you ejaculate before you want to, less stimulation, these are the few numbers given. So 0 means that there is no problem, 4 means it is a problem. Just the way we have to make a format and fill it, and score of 11 or more is commonly found in the men with premature ejaculation. And score of 8 or less suggests a man does not have premature ejaculation. So these are few scorings have to be done before we start treating a patient. How do we treat? So first of all, I think we will treat the mind. Mind is very important. Then some people use lidocaine sprays or some gels can be used, but be careful. Overusage, and in case we don't wash it properly, it can lead to priapism also. Then we use SSRIs. These are selective serotonin reuptake inhibitors. They are the reuptake inhibitors, and they can actually help the man to have more control over his ejaculation. Sexual therapy, behavior therapy are 2 important things. Sexual therapy we do give, but behavioral therapy, only counseling. I have not gone beyond that. I've never actually understood that part. I've not seen many people giving it also. So look at the synapse. We have the synapse occurring, and we have serotonin coming here and coming to the post-synaptic junction. And then it triggers off multiple reactions in the body. But the serotonin has to be, now it goes back very quickly inside. As it comes, it goes back. It doesn't get lost. It keeps it going in a circle. So now what we do is, in case it moves in very quickly, it'll get over very quickly. So what we do is that when we're talking about this, we start giving people uptake blockers. So they'll come and block this passage here. So we have more of serotonin in the junction. It'll have more time to act, and that's the way it works. So we are giving, when we have serotonin is coming down, it is not going back. We have given a blocker here. We have given a blocker to the patient here, And as a result, the serotonin is choking the junction. And as a result, we have more of serotonin and it works better. So we are actually blocking the reuptake of serotonin. So we call it SSRI blocking mechanism. Behavior therapies are start and stop. You start, then you stop. Squeeze therapy, distract the thinking. These are all given by Virginia, Morrison, and Johnson, and many people have worked over it. So the squeeze therapy, and these are the recommendations from EAU. So you find that some are strong recommendations, some are weak. So basically, we have to know that we have to treat any infections or any other associated dysfunction. We can use some sprays. My favorite is always Depoxitin. I give Depoxitin 30 milligram to the patient and it works pretty well for me. I find that both PME and ED are occurring together in a large number of men. So I give a combination of Tadalafil and Depoxitin 10 and 30. This is what I'm using routinely. So we have to know what to give to a patient, how to combine drugs. Last thing I want to cover for you very quickly is decreased libido. Decreased libido is a common problem and it occurs in nearly every man as he's aging. And looking at the libido, as he's aging, his battery is getting discharged. So as you look at some data here, around by the time it touches 50 years of age, a large number of men, his testosterone values are falling down. And as we go in the age, they keep falling down more. And it's occurring more commonly nowadays by the type of life he's leading. He'll have this problem about libido, the type of food which we have, the type of, he's got a mobile phone, he's got a laptop, wife is distracted, he's distracted. Then all things will lead to loss of libido. Low energy, fat, depression, increased risk of ED and low libido. This is there. And we have spoken many times with you that there's a reversal of T/E ratio also occurring. Reversal. This I won't talk here now. Multiple times we have spoken in the classes. And in case we give him testosterone, his fat may melt and he becomes better. But remember that when we give somebody testosterone, that will reduce his sperm count. So don't use testosterone. This is okay for an elderly man, okay for the man who already has a child, but not for any man. Here we have an Adams question. So I've shown you few questions before. I just go back to where I was, a tool kit here. So for erectile dysfunction, there are two tools. For PME, there is one tool. And for lack of arousal or libido, there is a tool called Adams tool. So in total, we have spoken about 2 + 1 + 1, 4 tools we have spoken. And I don't want you to just start treating the patient without assessing them properly. So tools can be a good marker for you, and you can ask him, and they are from St. Louis University. So you can talk to him one by one and you have some score in your mind. So a positive questionnaire is defined as yes answer to question number 1 or 7 or any 3 other questions. So in case he says 1 and 7, we are sure that he's got a problem. Or any 3 questions come together, we say that he's got a lack of libido. So then how will you rate your libido? So there are multiple things. It's terrible, poor, average, good, excellent. So these are all, as I've told you before, we have 1, 2, 3, 4, 5 scoring everywhere. So make a score, and depending upon the score, we have gradation in the Adams score. Hormonal dysfunction will diminish libido, and we have to evaluate all these things well. It should be straightforward questioning, medical interview. And as I told you, these things for me, routine IVF, new case will take around 45 minutes, but these take around 2 to 3 hours. It takes so much of time that I've stopped taking online counseling for such cases. I call them. Otherwise, I don't get a proper answer on the phone. So what is ADAM? ADAM is androgen deficiency in aging male. Androgen deficiency in aging male is the ADAM test. And how to do it, I've told you already. As per the American study, which I showed initially, 43% of men in normospermia have this problem. Men presenting with oligospermia have concomitant hyperandrogenemia in around 50% of cases. But imagine, we can't treat them and they have less libido, less urge, but we can't treat them with testosterone because it will lead to low sperm count. That makes it very challenging. And you have to know that exogenous testosterone is not allowed. That's one thing which we are not allowing our people to take. So that makes the treatment very tricky, but it's very important. Nonetheless, we should know how to diagnose it. Again, the outcome of European Urology Association, that we should give the patient, people who've got low sexual desire, we call them LSTs. So we can give them drugs and they do very well thereafter. But definitely we have to rule out problem with the prolactin, thyroid, or vitamin D, diabetes, hypertension. All these things have to be ruled out. Psychological stress, I always found that it is more studied in the female partners. In the male, we have not done much of work, but now it's catching on. But here overall stress is quite a lot, anxiety is there, and all these things, they start occurring to the couple. And there's a loss of sexual self-esteem. That's very important. I wanted to talk about this particular topic, but due to paucity of time, I'll skip this. I'm deliberately not talking about this topic. We'll connect sometime again, and we keep talking during our classes as such. I want to speak about lack of emission and retrograde ejaculation. Again, this will be in the class we'll talk. Today, I just want to give you a glimpse of aspermia or anejaculation. I think that's all. I'll stop here, gentlemen, ladies. I think we have spoken quite a lot. I've spoken for more than 1 hour. Just to summarize whatever we have learned, that normal male sexuality is very important. Evaluation can be life-saving. It is not only done. It is not only done to reduce the chance of his having good relations. It's also to save his life. So it can be life-saving in case you do it properly. It can save him a heart attack. So it can be, it's a window into improving men's somatic health. And by no means we should start giving steroids to any men who has these problems and who wants to conceive. Because in case we give him testosterone, he'll have problems. So all these things, few basic things we have to avoid are these things. They will help him becoming better. A lot of apple juice, a lot of apples are known to be good. I'm personally very fond of fenugreek and giving them goji berries, dark chocolates, salads. They're very good for his fertility. Strawberries are known to be improving his both PMEs and EDs. I'll stop here, gentlemen, ladies, and I'd like to invite you for our next symposium, and that's number 19 in seniority. There will be the 19th curtain reserve, and that's again on a big demand, how to select the right sperm for IUI or IVF. People want to know how to select a sperm. That will be talking in great details. So I'm stopping here, and I will like to take queries, and I'll hand it over to Akriti now.
Thank you, sir, for this wonderful session. Am I audible, sir?
Yes, you're audible.
Okay. So by this class, we got to know a lot about ejaculatory dysfunction, erectile dysfunction, and we also touched the topic of loss of libido. So now I would like to say thank you. Thanks a lot, sir, for enlightening us about this topic. And we will wait for our next class, and date of next class is 14th November, next Sunday, and we will see you again. So for now, I would like to say goodbye to all.
Any
If
questions,
any
Akriti?
query,
Any questions? Correct.
yes. If any query is here, then you can ask now. Sir is here to explain it or to address it. So one query from
Myself, sir.
Hi, Dr. Rama. How are you?
I'm fine. I wanted to ask about the epididymal cyst that is less than 11 millimeter and on one side, and it is accompanied by it was diagnosed because there was a pain on the left side of the epididymis. Any relation with infertility?
Yeah, definitely. Epididymal cysts are known to the people may have a low sperm count. Number one, all these cysts, there can be tenderness, there can be pain, there can be swellings. It's pretty common. We do get cases.
Okay.
Initially, we were doing only clinical examinations, but nowadays we are doing a lot of scrotal scans, and it's pretty common. In such a case, I think give him some antibiotics.
That has already been given, and he has been given a scrotal support.
Cameron Fort can be given. Painkillers can be given. You can give him some antibiotics. That's all you can do. In case
that's all has been given. And if the semen count is normal, then is it related with some problem to conception?
No. In case sperm count is fine, nothing. But then he may need a surgery. I think you can rule out varicocele and do a surgery also, because
no, there is no varicocele, no torsion, and the epididymal cyst he has been advised just to give a scrotal support and antibiotics.
Yeah, in case he has continuous pain, then he may need a surgery also.
He has got an intermittent, like on exercising.
Chhod dijiye. I think you should leave it and let him heal by himself. But in case he's symptomatic, I normally I do send him for the cyst removal. But
he cannot go for cycling.
Yeah.
Long cycling he cannot go. So he's driving by car. Otherwise, he used to drive the cycle.
Right. Leave him. I mean, nothing much to be done in such a case. But in case he is very symptomatic, he can get the cyst removed.
No, it's not that. It's not that. It is not related with infertility if semen count is normal. Na?
Yeah, correct.
Yes, that's the aim.
Cameron Fort works very well in my experience.
That is Cameron Fort is?
Cameron Fort are basically chymotrypsin. These are the enzymes.
Cameron Fort. I pronounce it as Cameron. That has
Cameron Fort.
Thank you, sir.
Perfectly fine. Perfectly.
Thank you, sir. Thank you.
Some more questions from the audience. First question is free or total testosterone, which is done for loss of libido, and what is the normal level?
Normal level depends upon which laboratory we are handling. The normal levels are normally, in case I'm not wrong, taken to be more than 250. I don't remember the units offhand. I think it's nanogram. More than 250 the normal units. But I think you look at the reference value. Some given picograms, some given nanograms. You have to look at the values given by the laboratory. But testosterone definitely is one test which you should do in every man who's coming to you after say 40 years of age. Testosterone with a low libido. When he has a low libido, do testosterone. And in case a youngster comes to you, even a young boy comes to you, I think we should do his testosterone, and it is low. But only point is that in a young boy, we cannot give him any treatment, because in case we give him testosterone patches or testosterone, then he will lose his sperm count. So normally FSH, LH and testosterone are three triad of tests which we can do for the people, which we normally do. But we don't treat low testosterones in a young man, because he will lose his fertility. That's all. The normal values will depend upon the normal range which is given by that particular laboratory. When the testosterone is low, you normally find LH going high. So that's one thing you have to always keep in your mind, which very rarely happens. Very rarely happens.
Okay. Thank you, sir.
The loss in fertility on testosterone is temporary or permanent?
In case testosterone goes low, this means that there is something going wrong with the Leydig cell apparatus. When Leydig cells are not working, then LH will go high and testosterone will become low. So testosterone pathological in the man will normally be associated with this. Normally we don't have testosterone getting affected in the man. So in the man, LH and testosterone will remain normal till the end. what is affected is FSH and sperm count. But in case you find that LH is going high and testosterone going low, in my experience, it doesn't revert back. It is a progressive condition, but it occurs very late. It doesn't occur in the beginning. We'll have always FSH going high and Leydig cell compartment is preserved.
Thank you, sir.
But don't treat, please don't treat with testosterone. Be very careful.
Okay.
Don't treat. Some people start giving clomiphene. Clomiphene is one method which is can be given, but clomiphene again should only be given when the levels of FSH are low. Otherwise, clomiphene won't work. So I think we should, as early as possible, try to retrieve his sperms and do his case. That's important.
Thank you, sir.
Yes.
Two small doses. Dr. Natish.
Yeah, Natish.
Sir, the first one, when the patient is having a retrograde ejaculation, so we generally correct the post-ejaculatory urine. And how to further process for testing whether he is having ejaculate or not.
So there are multiple methods available. Normally, urologists, they are doing �W𝐀𝐋𝐄 method, which we don't approve in our laboratories, because what we do is that we give them soda bicarb. Soda bicarb is baking powder. Baking powder can be given to the patient 3 grams 24 hours before the semen collection. Suppose you want to do his testing tomorrow or take a sample tomorrow. So we give him 2 teaspoons 1 day prior. And then before he gives a sample around 4 to 5 hours prior, we again give 1 teaspoon of soda bicarb or a baking powder. This will make his urine alkalinized. So now what we do is that we will encourage his passing urine. We'll have a lot of water. After he passes urine, the urine will become clear and it will have minimal amount of toxins in it. And then we will tell him to have some water and fill up the bladder partially. But this time he's already taken around 7 to 8 grams of soda bicarb. His bladder is filled partially, and then he's told to masturbate. And then immediately after he masturbates, we collect his urine. It shouldn't happen that we tell him to empty his bladder and then pass the urine. Then do the masturbation. In that case, he'll take a long time to fill up his bladder, and then the effect of urine alkalinization will go off. So bladder should be partially full. He should give a semen sample, urine, he should masturbate, and then urinate immediately. So partially filled bladder is important. 2 doses of soda bicarb is important. Take his urine into 15 ml tubes. Normally we get around 8 to 10 tubes from a man, because he'll give you around 150 ml or 200 ml of urine. We take around 8 to 10 ml in every tube, and then we centrifuge. And we centrifuge it for around 5 to 7 minutes at 1500 RPM. We'll find we get a pellet. Pellet is formed. The urine on the top is now removed, and we collect all the pellets in a new tube in Hippis buffered media. And before we spin it again, take a drop from there and look under the microscope. We normally get good number of sperms. So we wash that semen sample twice. Initially, we wash it for at 1500 RPM for 10 minutes, and then we will wash it at the same speed for 5 minutes. Then we take the swim up, and that sample can be used for IVF or IUI. We get good quality sperm, but remember that minimum 2 doses of soda bicarb, and before you collect the semen sample, he should have some urine in his bladder already. Otherwise, it'll take a long time. This is one method. Other method, you want to be very, very safe, which I am not very fond of, which I used to do around 5-6 years back, is that you give him soda bicarb and then you make him urinate. His bladder becomes now alkalinized. Then you put a Foley's catheter. You put a Foley's catheter and you put in around 100 ml of Hippis buffered media. So we used to take 1 bottle of Hippis buffered media or HTF and inflate his bladder with that. And now he's told to do masturbation. In that case, now here we are much safer, because we have already made his urine alkaline, number 1, bladder alkalinized, And then we have put herpes buffered media inside, which will support his semen sample. Put 150 ml inside, and then he's told to masturbate and take his semen sample. But here it entails catheterization, which I'm not very fond of doing. So I prefer giving 2 doses of soda bicarbonate, and that's it. It works pretty well for me. Yeah.
Sir, for routine semen analysis, these are
I have a hidden
not required,
question.
no, sir. Sir?
Yes. Yes.
Just continuing the question, for
Yes.
routine semen analysis, we don't want to give sodium bicarb because we want to make sure that the patient is ejaculate or not.
Yeah. That's for routine. Routine you're just checking whether sperms or not. Even if they're dead or they're damaged, we are not bothered. We just want to diagnose it. So first of all, the clinical diagnosis of retrograde I wanted to avoid today because it's a very long topic. Retrograde means that he's getting proper arousal. He's got a desire, he's got arousal, he's got proper erections, he's got proper ejaculation and resolution. Nothing comes out. Nothing comes out. Everything is perfectly fine. He's very happy, but he's got dry orgasm. Nothing comes out. In that case, you always have to examine the urine. Perfectly fine. I totally agree with you. Probably I didn't catch your question properly. I told you how to prepare the semen sample, but you take his urine here, take 1 bottle of urine, 2 or 3 tubes of urine, you'll get a pellet, centrifuge, and move it. That's for diagnosis. But for preparing, 2 dosages of soda bicarbonate. Remember that.
Sir, how much centrifugation, sir? 1,500?
I normally do 1500 RPM for 10 minutes and then 1500 RPM for 5 minutes. I wash it twice. Wash it twice.
Wash it twice.
Why wash it twice? And then we take the swim up.
So we should split the urine into 15 ml samples and examine all the pellets.
You'll get around. No. You don't examine all the pellets. You see, it's not possible that bladder के अंदर churning हो रहा है ना. It's not possible कि bladder में किसी part में आया, किसी में नहीं आया. It doesn't happen that way. The bladder is all mixing up very well. So it doesn't happen in the bladder that one spurt will have sperms and other won't have sperms. So here we do that we prepare around 150 ml of urine in his body by telling him to hold his urine for around 1 hour. After taking soda bicarb he'll take soda bicarb in the morning at 9 o'clock. 12 o'clock you call him and then make him pass urine, then make him drink some water. So all that muck has gone out. Now bladder is clean. Bladder wash हो गया उसका, समझ लीजिए खूब पानी पीने के बाद में. Now you take those tubes, give him a jar. He'll collect the semen sample. He'll normally take around 2 or 3 jars. Every jar is around 70-80 ml. He'll give you around 2-3 jars. Those jars you now transfer the urine into tubes. You'll get around 8-10 tubes from the man on average. So you will take 3-4 of them, spin it. You'll get a pellet. Mix up all the pellets. Throw the supernatant. Mix up all the pellets. You'll get a big pellet. Just mount it. You get a sperm. You know that it is a case of retrograde ejaculation.
Understood, sir. Thank you. And the semen processing sample, will you freeze it for future purposes?
It is not that we're going to freeze it for the future purposes. You may freeze, nothing wrong in it. But I feel that I always feel better in case I take a fresh sample from him. Freezing is always a backup that you can do. But getting a fresh sample from him, it will come. It has to come. He's a normal man. Once you know that there's a problem, you alkalinize and take his urine sample and get a fresh sample from him. But either way, you can freeze it also. That is not an issue at all. That depends upon you want to be doubly sure that you don't go wrong. You can freeze it. No problem at all.
Okay. So one last question.
Yes.
This is regarding a patient which I saw, but he is having seminal vesicle agenesis. He is having ED also. He is ED. Because of his seminal vesicle agenesis, the fructose negative, and he is having azoospermia. But his testicular volume, everything is normal. His testosterone is low, and but his epididymis is full. Can we try PISA and IUA for this patient, sir?
Natesh, इस केस के अंदर somehow I take his testosterone low with pinch of salt.
Okay.
It can't happen. It doesn't happen in my practice for 18-19 years. You repeat is such man who has got an EDO. They have got low fructose. They've got minimal low volume semen sample.
0.2 ml is having there.
Acidic pH, yeah. It's very common. It's very common in my practice.
But they're giving a pH as alkaline. That is what is confounding. The outside
No.
lab.
No, that is wrong. And you do it yourself. Check fructose will be absent or it will be absent. His pH will be low, acidic. His volume will be low. This is a typical case of either EDO or bilateral absence of congenital absence of vas deferens. Two things are there in this case.
But the cord is palpable, sir. But the trust assured he's having seminal vesicle agenesis. But there is no intraprostatic enlargement of the ejaculatory duct. So we don't know whether it can be cured or not. So we're going to PISA or IUI. He doesn't want IVF. That's why.
Fine. The IVF, though, isko IVF hi karna hoga. There is no other way out. Either, see, in case you do an ultrasound and you don't find any ejaculatory duct or a seminal vesicles more than 2.5 centimeter or 1.5 centimeter, in that case, you just, in case you don't want to do turret, do his PISA, TISA. That's good enough for him. He's got a blockage.
PISA and IUI is fine, sir, for him.
IUI नहीं हो पाएगा. IUI नहीं हो पाता है. IUI कैसे करेंगे? You'll get very low semen sample from him. Such a case.
They told you.
No. I don't think you can do an IUI with a PISA sample. I don't advise that because you're spending around.
No, I think CFTR gene first in this case.
Yeah, that's a different issue, madam. I'm not going to talk about. I'm not talking about that at all. That we already spoken. But I think you take his, do his PISA, TISA, whatever you want to do. Take his sperms and go ahead.
Okay, sir.
But IUI, no, Latish. I don't think IUI will work because you'll barely get few sperms from him.
Thank you, sir.
How much will you take out from his epididymis? You look at
0.2 ml maximum we can get.
0.2 ml is a 200 microliters is a huge amount. And when you start washing it, normally we get from a man 1.5 ml to do an IUI. 200 microliter, I don't know.
Understood.
It doesn't work out for me.
I just read a few articles, so I just want to confirm whether this is being practiced the advanced care center.
Writing an article, what does articles they say? They do an IUI at 1 million.
Okay.
So articles. In our classes, we have spoken a lot. 6 to 8 hours we talk about these things only for IUI batch. That you do IUI for 1 million sperm count. But then they write there is no pregnancy ever reported.
Okay.
So ideally cutoff should be 5 million. 5 million post-wash motile sperm count, which you should have. And from PISA sample, getting one sample, one out sperm and doing an IUI, you can do it. No problem. But it won't give you, it's not right. For an audience should know that for a research setting, you want to do some studies, okay. But for a man, you should be doing IVF ICSI for this gentleman.
Thank you, sir.
Okay.
So another question from the audience, from Dr. Archana. How to counsel patient having excessive weakness after the act?
There is no answer. Give him a lot of Giloy, I think so. Give him a lot of Giloy and give him a lot of multivitamins. That's all I can say. But I think you have to learn. This question also came from one of my students, one of my colleagues in Kolkata. She brought this thing up. It's a pretty common thing. And what you should do is that it's just counseling and they should bond better. It's more of a behavioral and psychological counseling. There's no drug for that. You give him multivitamins, CoQs, good diet. It's a weakness there is no methodology given. There is no magic for that.
It's the culture. The people, they take it that way. It's weakness, though it is a relaxation.
Yeah, it's a relaxation. So many women, they say that all the sperms, they fall out. They commonly say that the sperms, they come out. Sperms are supposed to come out. They are supposed to come out. So something like that. I don't have any answer to it. But I think basically the couple has to bond together. The wife and husband shouldn't take it as like a battle that it has to be done to get a child. They should come together as a team. That's simple. I don't have any answer to it. There is no drug as far as I know. But losing weight, looking at his thyroid, prolactin, vitamin D, lipid profile, they're important things.
Okay, so
or it could be the cardiac part.
Yes, it depends upon. See, there is actually no end to just ruling out. Yeah, correct. That's what I'm saying. But in case his libido is good, I won't go to ECG and TMT for such a patient. I think the first is most of behavioral and psychotherapy is it. But cardiac is yes, definitely. That's always there. But you can cardiac problems. can be delayed in case you have more regular intercourse. A lot of books have written that. Yes. Anybody else?
So another question from Dr. Deepa about distal sensory neuropathy leading to erectile dysfunction.
Kya bola? What did she ask?
Distal sensory neuropathy leading to erectile.
I don't know. I have never. Must be some sort of neuropathy. I am not clear about this. I'll have to read about this. It's a technical question, and I'll have to read about it. Distal sensory neuropathy. She's talking about some spinal cord injury or something. I don't know what she means by this. It's due to what I don't know. But for any spinal cord problems, I think Viagra or something works pretty well. But I'll have to read. She can send us the document. Let me read through it.
Hello, sir.
Yes.
Yes, sir, yes.
Okay, sir.
Cause of sensory neuropathy.
Yes. What is the cause of this? I don't know.
It can be due to diabetes
Sir,
also.
distal sensory,
Due to diabetes.
distal sensory neuropathy occurs in diabetes.
Yeah, that way. Okay, fine. Talking about diabetes or something, I think.
No, sir. He is not diabetic. He is hypertensive and he's got like peripheral neuropathy. And
Deepa,
he has
DSPN is a particular distal sensory peripheral neuropathy. DSPN is particularly used for diabetes neuropathy.
हाँ, मेरे को नहीं पता. We'll have to read about this. Deepa, एक काम करेंगे. We can share in the class sometimes. We can share, just share his reports and we'll read about this. It's a lovely thing. That's when new things come up. When we never go to that level. मेरे को नहीं पता. So we'll read about it. We'll talk about this. So distal neuropathy due to hypertension, I'm not aware of. Diabetes, yes, but
he's hypertensive, sir, but he's presented with these symptoms. So referred him to a neurologist, but then they just gave supplements and it's not yet resolved.
I don't know. We'll have to read about it.
Thank you, sir.
Sometimes we'll have to start referring patients to someone who's more intelligent. I think a neurologist can handle him better there.
Yes, sir.
Yes. Anything else from anyone?
Okay. These questions were from chat box. Any further questions from the audience? Okay, Dr. Sandhya.
I think before we say goodbye, we'll take you. Everyone should put on their camera and let's say hello to each other. We have not seen each other, and the batches. I think E1 to E8 course is going to end very soon. Let's put on our camera and say hi to all of us. And you just put on your camera and then we'll talk. Let me wish happy Diwali to all of you. We have some new friends here. Dr. Sen, how are you? You're driving somewhere? Hi. So many friends are here. I can't take all the names. Thank you so much for joining. Yes. What's the query?
So Dr. Sandhya is having some query.
Yes, Sandhya.
Sir, one doubt regarding HSG cannula.
No, HSG nahi, iske andar nahi. Alag HSG nahi. Anything about male sexuality you can ask. But I didn't have an answer to distal neuropathy. मुझे पढ़ना है. Homework for me. I've been given something to read for today evening. I'll read about it. Yes.
What is the treatment of delayed ejaculation?
This is a very tricky question, and this is my main bread and butter nowadays, handling these people. I don't know from where they come up, and there's no drugs for these things. But again, delayed ejaculation occurs mainly in obese people who are obese. It occurs in the men who are elderly. These two are the main people, two group of men, which it's documented to have delayed ejaculation. The ejaculation may not occur for more than 30 minutes. It is very, very frustrating for the man. I normally get one patient in every 8-10 days, and there is no answer to this query. But they say that the problems can be due to something wrong with the, again, sensory system. Rule out diabetes, hypertension. These two things have to be ruled out. Thyroid, prolactin. I have done all in my patient, but I've never found any other. So this problem normally occurs in elderly men and the men who are obese. I think counseling is the only way, and they can be told to relax. There is no pill to make them ejaculate at the right time. There is no pill at all present. The only thing which books have written, and if you go to European Urology Association and American Urology Association, They say that more amount of foreplay and more amount of bonding can help that couple. But there are no drugs to have early ejaculation. I've not found any drug as per the literature. But it's a burning issue.
So
Yes.
it is a extreme form of premature ejaculation in a case like
It's
that.
It's a delayed where here
But I mean to say in the reverse order.
It's a resolution doesn't occur for more than 30 minutes, we call it. But in case somebody has any answer, I would love to hear from you, because in my practice, I have handled around 10-15 cases and I'm never able to give an answer to this query. There is no answer.
Sir, some people occasionally.
Good morning, sir. Good morning, sir. Dr. Aarti here. Sir, I just want hypo patients. They get treatment for just to get some some amount of sperm count. They get treatment like some people give SCG or some give FSH, any kind of treatment, not testosterone. They have been treated and they feel that they have a good libido. Sir, can you hear me, sir?
I can hear you. I can hear you.
Yes.
I can hear you very well, loud and clear.
Okay. Sir, and they get all the problems were corrected, like sexual desire and erection was corrected. But now when the no result with the sperm count treatment is left, for the last 2 years, they got treatment and then treatment is left. Now the thing is again with the erectile dysfunction. So what we should tell them, just to go for right, because this is hypo.
This part we have covered at great length in the classes. So I won't like to elaborate here, because simple thing you have to know, Aarti, is that in hypo, they have no testosterone, they've got low LH, low FSH.
Yes.
This you all know. They would go volume semen sample. In hypo, in case you really want to, once you give them HCG, you start getting testosterone. And when testosterone comes in the body from the LH and the Leydig cell functioning, he's able to get his libido back. Definitely get his libido back. But after we stop the drugs, the libido goes off. So in such a case, the right answer to such a problem is that you diagnose hypo, number one. After we have diagnosed it, you stimulate him, get his sperm, freeze them. After we have frozen around 7 to 8 vials of a semen sample, which you can use it for IUI or for, because they take around 4 to 5 months to get ready. After 4 to 5 months after his sperms are ready, then at that point of time, what you can do is you can carry out his semen freeze, and then let him go. You can't give it lifelong HMG. Some people give lifelong GnRH pumps or many things, but it doesn't work out. It's pretty expensive. People can afford that type of treatment. At one point of time, I have around 1 or 2 patients running all the time with HMG and this sort of drugs. I think you just pull it on, take him till the time is able to give the sample, at least minimum 8 to 10 vials, and then you can give him testosterone supplements.
Okay. I would like to
supplements, but after freezing his semen sample, so that he can undergo IUIs and IVFs, and I think better option.
Okay, sir. Thank you, sir. Thank you.
Sir, can I just put in a word, sir? I'd like to. So can you hear me?
Yeah, we can hear you very well.
Yes, sir.
Sir, I mean, as I have whatever little experience I have observed that such people are extremely traumatized as a couple. My suggestion, since you're an industry leader, so shouldn't there be, like the psychosexual counseling part? It should be part of the IVF teams or probably the units, because they're very troubled couples and they don't know where to go. And many a times, the only answer is not giving them a pregnancy alone. So I do not know how practical this is, but
It's already there. It's already there in every unit. I've told you, I've been telling you people from 2 years that the whole of sexuality is our domain, but we don't talk because we want to quickly see a patient.
Lots of people don't do it. So we, I mean, what the point? Yeah.
So it's not not the part of who's going to do it. I always say it's you who's going to do it. So why I have picked up this controversial topic today? I've told you that the amount of experience I have, though I didn't know about sensory neuropathies leading to penile dysfunction with hypertension, but I've been seeing such cases from ages. They find that the women don't see them.
Yes, sir. The majority of the people don't, and like this is a real lacuna there in the.
Gynecologists don't even sample. They don't even know the normal sperm count that you're doing IVF.
That of course, sir. But basically the point about, you know, actually speaking to these people and sorting out this particular problem, the psychosexual dysfunctions, this is, I think, of paramount importance, because people do give them an IUI pregnancy, people give them, lead them on to IVF, but they don't treat the root cause.
Right. So when I took the cross sectional from the country, I wrote to all my young gynecologists, girls who are very young in the specialty. Few states they gave a lot of queries. ऐसा भी होता है, men talk, women talk, but some states are zero. Actually zero. They say we don't know that the problem even exists. That too by the doctors who are doing IVF day in day out. They are not aware. They say हमारे पास कभी हमसे कोई बात नहीं करता.
So they don't want to. They don't want to spend time there.
Yeah, so this thing is part of our charter of duty. I've given you 5 questionnaires which you'll have to now. I don't say start filling the questionnaire. Let people do it for you, but you have to read about it. I think I want to link to. Yes.
This is Dr. Gupta here. I
Yes.
want to ask one question. First 2 questions, sir. First of all, I want to know the doses of the penile injections and what is a regime. Second, the doses of the testosterone.
I don't give penile injection. I don't give penile injection at all. Penile injections should not be given at all to the patient from our side, because they can lead to priapism. So the priapism problem is a major issue. So it should be given by the urologist only. It should not be given in the OPDs like the way we were giving before. That should not be given. That's one thing I would like to tell you. It's a very, very good method to inculcate confidence in the men, that can be done, but only under supervision of a urologist, not by us. But we should know that we have to refer that patient to the urologist. Like giving some sort of prostaglandins in the urethral meters, we should not be giving it. We should know that it can be done. And it's done by the urologist, not at our end. Regarding testosterone,
Yes, sir. Because in the late night, I have got an emergency of parabism of one of my patients. He has got to.
What happened there? Very interesting.
In the night he got a parabism because the penile injection. So they have come to my hospital in emergency. See, lot of pain and everything.
Achha.
So I have to take in the OT. I have to drain it from the dorsal vein by consulting with the urologist.
Achha, how did you do it? How did you do it? Very nice thing.
Sir, dorsal vein से just a veiny section जैसे अपन blood निकालते ना.
अच्छा.
बस वैसा ही है. Dorsal vein से.
What was the methodology they use for that?
Nothing. It is very simple, sir. Just you have to puncture the dorsal vein with a 20 ml, 20 fine scalp needle.
Achha.
That's it.
Which is, and how much blood did it take? How much blood did they take out from the man?
20 ml. 20 ml.
20 ml. And then it became fine.
Yes, sir.
Amazingly. कब हुआ था केस ये? What time? When did you have this problem?
Sir, 6 months back.
And who had given him testosterone tablets? Was he given something for his thing?
No, he was given the penile injection for a home होम रेडीमी के लिए उसको पेनाइल इंजेक्शन का ट्रेन किया था और वो बोला था कि आपको अभी भी रात में कांटेक्ट रखना है तो यू डू दिस लाइक दैट।
किसने
तो
दिया था?
उसने किया, लेकिन आई डोंट नो अबाउट द डोजेस। यूरोलॉजिस्ट में दिया था, सेक्सोलॉजिस्ट या यूरोलॉजिस्ट था, आई डोंट नो द डॉक्टर्स नेम, but he was something that sexologist or urologist was there.
Acha.
So they have came with the emergency like that. So I have to intervene and I have called the doctor what to be done. He guided me. Nothing is worried. Just you have to clean and drape it, just like a circumcision. What you do, you just have to puncture the dorsal vein and you have to collect the remove the drain of the blood, 10 to 20 ml. Okay, and he will be fine. इसके लिए मैं आपको पूछा सर।
नहीं, I have got no experience. We don't do it because it's not the right thing to do it also. I personally feel we shouldn't be doing it because in case you do it, then there can be a problem like this which you face at your end. So priapism is a major problem in such cases and we should be very, very careful about using such things.
नहीं सर, प्रॉब्लम क्या आता है कि पेशेंट है ना एंजाइटी में करना, they take the overdose.
No, this means that patient was taking the drugs at his home himself.
Yes, himself injected it.
अच्छा.
Because अपना जैसा ये रिफिल कार्ट्रिज कैसा आता है सर, FSH का अपन मैनिपुलेट करते हैं ना, होम घर पे भेज देते हैं ना पेशेंट को होम पे, उसी तरह से उसको रिफिल कार्ट्रिज के जैसा ही था. You were just injecting there
before the act.
That's why I was asking the thing.
No. I think
yes, correct.
This is not the right thing to be done, and this can be actually killing for the men and many of the men. But I didn't know that you had this. Experience.
That's why I was asking this thing. कि उसका क्या डोज रहता है? I really don't know.
No, हम use नहीं करते. I told you, no, we don't use it. These things, and we should always our job should not be going into the domain of a urologist. We should not be doing it also.
We should. At least we should know what the doses are going on.
Yeah, correct. But we don't. Papaverine, any intracameral injections, PRP, even testosterone tablets. We should be careful. I think we should be tablets any testosterone.
नहीं मैडम सर, they have a 3 drugs doses combination है उनका.
नहीं, वो हर जगह से different. That's what I'm saying. It is their domain. So we should not go into. See, we are not a urologist, no. See, the scope of work and there we don't treat these urology drugs. Like you said, how much testosterone is to be given. So some people use gels, some use sprays, or give 5 or 10 milligram tablet a day. Here again, I will just request all of you. You want to give testosterone or 10 milligram tablet or 1% gel sprays. Always refer them to a urologist. Don't start treating. Our job is enough in case we're able to diagnose them properly. That will be behavioral counseling should be our job. Doing a surgery on them in case we are trained is our job. But giving them intracameral or those sort of things we should not be doing. Even for testosterone, I'll say that in case you want to start somebody's testosterone tablet, you must, or a gel or a spray, we should refer them to a urologist and let them handle this. That is their domain. Something goes wrong tomorrow, it will become a medical legal thing. So that's the point.
And at least we should be in a gynecology, we should know, because when it's an emergency, our patient comes in our clinic, we don't know about the doses and all this. They ask us, that's why I was asking.
And you're right, but वो patient को आपके पास में नहीं आना चाहिए. That's what I want to tell. See, मैं 20 years I am in this field, and we have faced these problems around 2003-04, where we found people going into priapism. Then we have look at the literature. World literature says it's not our domain at all. Our domain is to just find out that they are having a problem and carry out their IU or IVF. Meanwhile, refer them to urologists in case you feel that they need a penile transplant or they need some sort of more therapies. They should go to a urologist. I personally feel that because medico-legally, we will get caught into this. That's an issue.
Okay, sir. Okay. Thank you, sir.
Yes. I think we'll now say goodbye. And any other query? Any last quick question? Then we will say goodbye. If none, I will now invite Dr. Garima to say hi to all.
Hello, sir.
I'd like you to sum it up. We have some question coming from Dr. Imadi. Yeah, Dr. Imadi Mahesh Babu. No, I think he's not able to reach us. Dr. Garima, I'd like you to just sum it up.
Yes, sir, sure. So as usual, your lectures are quite, the complex topics into a simplified manner. So to have a comprehend knowledge of the subject matter is one thing, but to deliver it in a simplest manner, it is altogether a different dimension, and it is an art. So basically you are an artist in that way. So it was a very nice topic and very sensibly dealt with. I just found out some literature on the neuropathy regarding the queries which were going on. I have sent you. Maybe that might be of some use to you. So I just I was just going through the internet. But thanks a lot, sir, and thanks to everybody and IC platform to make me the honored guest today. Thank you so much, sir. Looking forward for the next curtain raiser.
Yeah, we'll meet next Sunday. And meanwhile, I think that this diabetic or hypertensive neuropathy, I will also go and read.
Definitely, sir.
Thank you, Garima. Akriti, all yours, and then we can close it. You're not audible. You are on mute, Akriti.
Hello.
Hi, Dr. Mahesh. You wanted to say something?
Yeah, good morning, sir.
Good morning. Good morning.
Yeah, I am Mahesh from Pediatric Center from Hyderabad, Department of Radiology Department, sir.
Okay. You want to say something, Dr. Mahesh Babu?
Yeah, yes, sir. Hello.
Yes, sir. You are audible, sir. Hello. So, do you have any query, or do you want to ask some question?
You've raised your hand. No, he doesn't. No, so
Okay.
Yeah.
Yes. Thank you, sir, for this wonderful lecture. As Garima said, that it was really wonderful and I think the simplest way to understand anything. And thank you, ma'am, for being with us throughout this session. Now it is time to say goodbye, and we will see you again on next Sunday, 14th of November, with our topic selecting the best sperm for IUI and IVF. So it is like goodbye for now.
Thank you so much, everyone. Let's meet next Sunday. But meanwhile,
hello.
Yeah, hello.
Hello, sir. Can you hear me? Good morning, sir.
Hi, we can hear you, but we can't see you.
Sorry for the late questioners, sir. Actually, I have a doubt. Like in female, you say like we have classifications like type 1, type 2, type 3, like that. Based on hormones like testosterone, FSH, LH, do we have any values based on the treatment for males, sir?
What type of treatment?
Like FSH, LH, total testosterone and free testosterone. If the semen analysis is abnormal, how can we evaluate the male partner? If suppose the semen analysis is abnormal, if they have a low count, so based on FSH, LH and testosterone, how can we classify them or treat them?
We had a big lecture of around, I think, 4 hours. We have 3 of them we have already had. You can just go to our curtain results, you'll get all the answers, previous ones. We've covered everything there about the reproductive endocrinology. We've spoken about how to evaluate the man who's got azoospermia or low sperm count. We have covered all of those things. It's a very major topic to cover up here, but I think we'll have to, there is no need to do LH, FSH for every man. There are indications I've covered at great length, Trevor. I think the best will be that you go to our curtain raiser and see those previous ones.
Thank you, sir.
Paucity of time, I can't take that long question now.
Thank you, sir.
Okay, so you can go to our curtain raiser. It's a big series. Everything has been covered there. So
thank you, sir.
Thank you so much, everyone. I think we'll stop here. And thank you, Akriti. Thank you, Garima. Thank you, all of us, for joining us in such large numbers. And we'll see you soon. We'll see you on next Sunday. Thank you so much.
Have a nice day, sir.
Bye.
Sir.
Bye.
Bye.
Thank you, sir.
Bye. Bye. Take care. Bye, everyone.